what the heck is sciatica? And it was always something that I was never really happy with the diagnosis because it wasn't very specific. But then the problem is we can't really be very specific. I think what we can do is try to, where we can, rule anything out, anything nasty. And hopefully by the end of this session, you'll see what we mean. If we skip back to last week, we were looking at referred pain. You can get referred pain down the back of the leg, which can come from the joints, it can come from the muscles, and it's usually where they share the same nerve root as the region that's sore. So if you have an issue with the sacroiliac region or the lumbar spine and irritation to the joints around that region, you can get symptoms down your leg. And then people are really worried that they've got sciatica and they've had a disc herniation, but it may not be at all. But the problem is that if you get an MRI done, then quite often, especially if you're in your 40s and 50s, you will have a disc herniation. It is part of the way we are. So then the herniation gets blamed for the pain, but it's not as simple as that. And then you've got radicular pain. That is pain from a nerve root. There is some irritation to that nerve root and you're getting symptoms because of that. You may or may not get symptoms. So you can have nerve root compression, no symptoms at all. You can have the slightest of nerve root irritation and there can be lots of symptoms. So there's lots of things that contribute to pain. It's not just the anatomy. We need to take that into consideration as well. And then we have radiculopathy. And the radiculopathy is really key because that's very different. This is when there is such an extent of either nerve compression or some kind of irritation to the nerve root that it is interrupting the nerve impulses. We get a loss of sensation, we get loss of motor control, so a weakness potentially, and we may get a dulling down in reflexes. That's different. Radiculopathy is where we can measure doing a neurological exam and we get all of those changes. We need to be as specific as we can, but where we can, depending on what you can test. But yeah, it's not as simple as I've got pain down the back of my leg, it must be a disc. That's the kind of key message. And that's really important to let people know, because they will Google their symptoms and then that's what it will come up with. It will come up with a nasty picture of a disc popping out and it will scare the bejesus out of them. So yeah, we've got to be really careful with our language. So we're going to delve into, well, what actually happens then when you have a disc herniation. We're going to go back over herniations again, a brief recap of that, and then we'll delve into what actually causes the irritations. This is the recap on herniation. We looked at there's not usually an inciting event with these. It's not often where you do something and then it goes. It's usually something that happens over time, and sometimes it's really innocuous, literally like, I don't know, sneezing, doing up your shoelaces, picking up a bag of shopping, and then they go, God, all I did was pick up that shopping and then my back's gone. It's not that something is all of a sudden just ruptured. This would have been some kind of gradual, slow process. And we'll look at the kind of things that causes irritation that will cause that nociception, which is danger messages, basically alerting your body that something isn't quite right. Due to the slow nature of what we call radial fissures, if we have a look here, this is the annulus fibrosus. So we looked at that in detail before, and you can see the nucleus pulposus just kind of seeping through. And then as you get more and more fissures in the annulus, then it can come all the way out, and it can come all the way out to the edge, and sometimes it will come outside of the disc as well. These are the various different grades, and we will have the majority of these will have all the time. Over the age of 20, we are going to have some kind of changes in our discs. They can often have symptoms. People have no idea what caused it, and it's because it's just happened over time. It doesn't go from, usually, unless there's something traumatic, from grade 1 to grade 4, like boom. It's not like that. This will happen over years. But then also, our body will adapt to this. We get these changes and they're just kind of normal part of the aging process, really. We shouldn't be too freaked out that we've got these changes. I think David Butler, there's a chap called David Butler, if you've not heard of him before, he mentions that we've got wrinkles on our face, unfortunately, as we get older. These are wrinkles on the inside of our body. That's a nice way of explaining it to people who are a bit freaked out. These are the kind of things that can happen then. Getting oxygen into the disc, nutrition, and eliminating waste. Again, we've covered this before, so just a brief recap. Only the outer few millimeters of the disc have a blood supply. The end plate, which are these bits here, the end plate of the vertebra, they're not closed off. It's more like a filtration system than a plate. And that's how you get your nutrients into the disc. The nutrients come from these blood vessels here that then feed through the end plate of the vertebra into the disc. That's how we get our nutrition into the disc. Nutrients from the vertebral body is drawn into the disc via something called protoglycans, and we're going to talk about those in a sec. They are, if you remember back to a bit of physics, negatively charged and draw in water, which is neutral, to try and get some homeostasis, and they draw that water in from the bone marrow. These protoglycans, these are the things that keep your discs hydrated. And the way that they work is through something called imbibition. So when you squash a disc and then let it go again, it draws in the nutrients from the vertebral bodies. That's how we keep our discs hydrated. We've got chondrocytes, which are cartilage building cells, and these help to build the discs. And then we've got something called matrix metallopeptidases, I think that's how you say it, MMP enzymes, and these clear away the waste. Again, we talked about this in detail a little time ago. In essence, this is what it is. The protoglycans are the delivery mechanism. Chondrocytes are your builders, your friendly builders. And then the MMP enzymes are your refuse collectors. That's a nice, easy way of working out what's going on with your disc. So what happens when you get a herniation? We get a breaking free of the nucleus pulposus through the annulus fibrosis. This is what's happened. When the annulus has been breached, so if we think about the down wall as the edge of the annulus, the protoglycans basically have a party, because now they usually just draw in fluid from the end plates, but now they've got your whole spinal column to get nutrients and water from. So it goes crazy and it will suck in loads of water, and it can double, the disc can double its weight within 4 hours. It literally just draws loads of water in. This was the only way I could kind of get my head around it. This is the annulus and this is the disc. So it's the other way around. If you imagine that the protoglycans just sucking in the water into the disc space, which is here. So you get this plumping of a disc. And then basically, I managed to find this on the internet. So the delivery team basically have a party. They're able to get all of that water in and they go crazy, and there's just delivery drivers everywhere. The herniation is not just the nucleus. It's not just the middle of the disc, but bits of the annulus, bits of these rings around, bits of the end plate, and bits of the bone as well, the bits of the bone from the vertebra above and below. If it's a really large herniation, it can then trigger the body's immune response to injury. And that's a good thing because it can help the disc reabsorb. If it's detected, then it can help get rid of it. The size of the disc bulge is, if it's bigger, then it's actually sometimes a bit more beneficial. Again, everything has its caveats. The bulge the name of the bulge will depend on what's happened. Disc tissue, which extends beyond the edges of the apophysis throughout the circumference of a disc. If it's more than 25% of a spread, if we have a look at this is your normal disc size. It covers the vertebral body. If it swells to more than 25%, then that is called a disc bulge. That's what a bulge is. All right. So if it's more than 25% of the normal width of a disc, then that is called a bulge. And you can have asymmetrical bulging, so it can come out one side more than the other. Then we've got, and these are all terms that are used on MRI. You will have, if you get access to MRIs, then you'll see these. Then we've got the difference between protrusions and extrusions. A protrusion is where the base, in this case the blue line, is thicker than the head. It's thicker than that bit there. That's the material that is herniated. We've got a focal protrusion, which is here, and then an extrusion. Apophysis is the outer edges of the bone. Yeah, if you imagine looking top down on the vertebral body, that will be the edges of the bone. If it extends beyond those edges by more than 25%, then that's a disc bulge. An extrusion, the head, the red line, is bigger than the base, which is the blue line. That's the terminology. That's the nomenclature for a disc bulge. But we're starting to get into the kind of finite details. So these are the terms that should be used on an MRI. Now, sometimes you can get a sequestration, which is a type of extrusion. Basically, as if you're sequestered, then you're secluded, and basically it's come out and separated from the disc. We've got a free fragment of disc material with no connection to the disc. That's a sequestration. And again, you may see that on an MRI report. Sometimes they're contained, these herniations, and sometimes they're uncontained. So contained, they haven't broken through the posterior longitudinal ligament, and that's that ligament down the back of the spine. We covered that weeks ago, so hopefully you remember that one. And if it's uncontained, it's broken through that posterior longitudinal ligament. And uncontained are surprisingly less trouble in the long run because the immune system can just clear them up. If it's floating around outside of the posterior longitudinal ligament, the immune system will eat it up and get rid of it. So uncontained can sometimes be better than contained herniation. So again, we need to explain this to people that it's not such a bad thing if it is uncontained. So the location of the herniation, the name that it's given depends on where it's come out, and that also can influence the area that it's affecting. The locations of the herniations can be central. If it's coming out there, then this is not likely to cause radicular symptoms. Remember when we looked at radicular symptoms last week? Those were things that affect the nerve root. And because the nerve roots are either side, a central protrusion is less likely to cause radicular symptoms. However, if it's big enough, then we've got another problem. And we talked about this. This could be cauda equina, because if that's a big enough compression that pushes onto the central part of the cord, then it can cause cauda equina. And that is a real serious problem. And we'll talk about that a little bit more in a second. It's a strange one. I did a talk with Dan Lawrence from the Physio Channel and Rock Tape during the lockdown period, and it was about cauda equina. I'll see if I can find the recording, and it's on YouTube. But basically, cauda equina is one of those things where they said when you get red flag symptoms, so you're waving the red flag, you should actually wave the white flag, because by that time it's too late. We need to pick up symptoms of cauda equina early so that people can have surgery quick. Really, really important. And we'll talk about why in a second. You can have paracentral. These are the most common. The annulus is weaker here. And if you remember where the posterior longitudinal ligament is, it's right at the back here. Sorry, these are the other way around. It's a bit confusing. Here's your vertebral body. Your posterior longitudinal ligament is here. That's quite a thick ligament on the back of the vertebral body. If you get a herniation, it's more likely to be drift out to the side of that posterior longitudinal ligament. And then that will impact near where the nerve roots are. So paracentral is the most common. The annulus is weaker there, and there's less protection from the posterior longitudinal ligament as well. It's more likely that you'll herniate paracentrally, just to the outside of the posterior longitudinal ligament. And then you can have a foraminal or lateral herniation. These are quite rare. These can irritate the dorsal root ganglion. They're so far out that they impact where that sensory nerve is, and that's dorsal root ganglion. These are, like I said, quite rare, these ones. This is the most likely herniation that you're going to come across. And obviously, whether it's protrusion, extrusion, sequestration, whatever it is, will depend on the findings. We won't be able to tell that from the symptoms that someone's got, because you can have no symptoms whatsoever and a huge herniation. The correlation between symptoms and anatomy is generally quite poor. So how do they get irritated then? We've got a couple of ways. We've got mechanical irritation. And this is something, the chap's name is Tom Jessen. It's where I've got a lot of this information from. He's written a really good book on sciatica. So well worth having a look. I think he's rewriting it at the moment and updating it. But it's, yeah, there's a lot of the stuff in my slides that I've got from him. Mechanical irritation, he calls it bowstringing. Basically, if you imagine the nerve is a guy rope on a tent, and then you're having something push on that guy rope, it bends it and it kind of deforms it. We've got a mechanical irritation on the nerve. If you push on a guy rope, it absorbs the force, obviously to a certain extent, but it can also deform the nerve. That's one way that you can get mechanical irritation of a nerve. As it's coming out of the nerve root, wherever that herniation is, it's pushing and it's bowstringing the nerve as it comes out. That's one way that we can get mechanical irritation. Another way is compression. Compression, if you imagine that that is the material, whatever it is, the herniation, what we usually imagine is happening to a nerve root after a herniation is this. This is where the nerve has been compressed and whatever material has leaked out is fully squashing that nerve. We've got compression and bowstringing. Now, the other thing that can affect it, and it can affect both of the other two as well, so bowstringing and compression, is what we term crowding out. If you think about the changes that you might see on someone's MRI, there might be some ligament hypertrophy. And we talked about this ages ago. And one of the things where if you're involved in a car accident and you get flung forward, like in a whiplash, that really kind of stretches the ligamentum flavum, which is at the back of the vertebral canal. And that injury to that region will then cause it to hypertrophy and thicken. What that does is it then encroaches on the available space for the nerve roots. You can also get fatty tissue deposits within those gaps, and you can get osteophytes, which are little bits of bone growth that also start to fill the space. If that's your nerve there, and we've got all this going on around that area, then it's going to affect the blood supply to the nerve, potentially. If there's a limited space in the intervertebral foramen, increased fat deposits, other space occupying lesions, if there's a tumor or something like that, bony spurs, osteophytes, ligamentum hypertrophy, ligamentum flavum usually, and then your blood vessels are in that region as well. All of that is in that space around where the nerve exits, that nerve root. What happens then when you irritate that nerve? Sorry about the picture. If we go back to the way that what a nerve looks like, we've got dendrites all around the outside. These are your kind of feelers that are detecting information, receiving information from other nerves, and then passing that information along. There's a cell body. This is a motor neuron. There's a cell body in the center of those dendrites. Then there's an axon, which goes all the way down here. The axon is covered in something called myelin. And myelin is fat. And it's the reason why it's there is to conduct the nerve impulses. Fat is essential for nerve conduction. And then right at the end here, we've got these little feelers, the axon terminals or axon terminali. And what will happen is you'll get an impulse come into the dendrites. And if there's enough of an impulse, there'll be a threshold level that is reached. And then that will propagate. It will send a nerve impulse like this here all along the nerve. There's lots of positive and negatively charged ions inside and outside the nerve. And basically it's like a wave. The signal comes in here. And then that signal is then passed on to the next section, which is here. And then this bit then starts to repolarize itself, change the positive and negative charges, and then all the way along, and then it's ready to go again. The propulsion of a nerve impulse along the axon requires energy. All of this process, receiving information, sending that signal along the nerve, needs energy in the form of ATP. And I'm not going to go too much into that, but basically you need fuel and you need oxygen to create energy. Mechanical deformation of a nerve can cause something called a conduction block. And depending on the type of irritation, the mechanical irritation will depend on the kind of block that you get. Some blocks, or one block, is worse than the other. The nerve basically can't function and the impulse just fizzles out. It's not able to send that signal along. If we think about some of the symptoms someone has with a radiculopathy, where you lose sensation, you lose motor control, and the reflexes are reduced, this is the kind of thing that is happening. The nerves aren't able to send those signals, and that is why we get the symptoms that we do. We've got two types of conduction block. With mechanical pressure, you've got something called a reversible conduction block, which sounds good. And then this one doesn't sound so good. This is irreversible conduction block. This one we're going to have a look at first, this green zone, and it's like this. The reversible conduction block from mechanical irritation is like when you cross your legs. Okay, so if you cross your legs, you've got a very superficial part of your peroneal nerve, which is right close to your fibular head. If you cross your knee over, one leg over the other, so if you do it for a certain amount of time, you will start to lose sensation in that region there. And because you're compressing the nerve impulses will get mechanically irritated. They then can't send the impulses or receive the information from that area. So your foot feels a bit weird or the side of your shin feels a bit weird. But as soon as you release it, it comes back to normal again. Really, really common. It's like when you're reading a book in bed and you're basically putting a real big stretch on your ulnar nerve and it makes your little finger go tingly. But then as soon as you move your arm, then it comes back again. That is a reversible conduction block from mechanical irritation. If it's coming back quick, then that's good, that's fine. It won't like it if you keep on doing it. Basically what happens is, this is your normal blood flow. The blood coming in to the nerve. The oxygen is then used by the nerve to create that cascade of nerve impulses. And then the blood coming out is at a low pressure. What will happen when you compress it, whether it's through the crowding out or whether it's through a mechanical irritation, is this. So the drainage of that nerve of blood is becoming impeded. Blood coming in to the nerve, the oxygen is used by the nerve, but then the blood struggles to get out. So we get what's called venous congestion. Venous is to do with the veins. Basically, the blood coming through, it then gets a bit stuck and a bit congested. That can be mechanically, or it can be crowding out, like in the picture that I've done here. And that is one of the reasons why we get these changes to the nerves and the way that they function. With venous congestion, the blood is struggling to get out, so you get a buildup of fluid, which is called edema. And then the edema causes mechanical pressure. And the mechanical pressure causes venous congestion, which causes edema, which causes mechanical pressure. We get this cycle of edematous tissue in the region where the nerve has been affected. That's one of the main things, and that can be a problem. It can be a physical thing that you can't change, so like crowding out, if you've got osteophytes and things like that in that space. But it can be reversible, like with this test. And if you've not seen it before, this is something called Phelan's test, where when you do that, you compress the median nerve. If you do that, and within that space, it's a bit edematous. That's quite common with, especially ladies who are pregnant, they get a lot of fluid in the extremities. It can reduce the space that's here. So when you do that, the nerve gets compressed and then it can't get blood. So it makes these fingers go numb. And that's what Phelan's test does. It's a reversible conduction block. You hold it there for a minute, and if your fingers go a bit funny, then we've got some kind of compression and mechanical irritation in the wrist. That's what that test does. The good thing is, there's no underlying structural damage to the nerve, and once the edema is cleared, all good. How can that happen? Movement is medicine. Yeah. So if we've got an area of edematous tissues, we've got some buildup of fluid, if we can get that area moving, then happy days. What happens though, when you've got a bad back, you've got this weird sensation happening, and then you read on the internet that you've got cancer. You get absolutely scared to death to move. So you brace everything, and you're just really, really worried about everything. Our big part of our job is to have a look at all the signs of what's gone on, whether there is a likelihood that it's something quite nasty. But if it isn't and the signs are good, we need to get them moving, because the movement is going to help to shift that edematous tissue, help restore the blood supply to the nerve, because nerves are really blood hungry. And if we can get that blood supply back to the nerve will be happy again. It will be able to create those impulses again, and then everything's good. So that is a reversible conduction block. Now, we're going to have a look at when it becomes irreversible, which is obviously not so good. If we remember this was where the drainage was impeded. We've got potentially crowding out of an area, or it could be just a temporary mechanical compression like we saw with the crossing the legs or the Phelan's test. We've got high blood pressure coming in, which is normal. That should happen. The oxygen is then used by the nerve in the middle, and then the blood struggles to get out, and we've got this venous congestion. That's that scenario we looked at before. Now, with an irreversible conduction block, the problem is we've got an issue with getting blood in to the nerve. Now, rather than there being this kind of venous congestion here, the nerve isn't actually getting any blood in the first place. And that's a real problem. Okay? That's a real problem. What we get is something called ischemia. Basically, you get insufficient supply of oxygen to the tissue to meet the demands. The nerve is requiring blood, but for whatever reason, there's some kind of blockage that is stopping the blood getting to the nerve. That's a big issue, because with ischemia and lack of blood, you get necrosis, which is cell death. That's not good. And the bit that dies is this bit. Without blood, the myelin sheath, which is that fatty tissue that's wrapped around the axon that helps to send nerve impulses down the axon, the myelin sheath starts to get damaged, and the nerve impulses just can't get there. If that has too much damage and it's not seen to quickly enough, that will die, and then we're in trouble. This is the kind of things that will happen with cauda equina. It's a compression that is so compressive, whatever the problem is, whatever is occupying that space to cause that compression on the nerves is cutting off the blood supply to the nerve, so then the nerve starts to die. And that is obviously not good. This is why early radiculopathy testing is really key. We need to do reflex testing, test the myotones and the dermatones. For me, in my clinic, whenever anybody complains of any kind of tingling or numbness, even if I just think they've slept on their arm funny and they've cut off the blood supply to their arm, you know, like when you're lying in bed, you shake it off and then it's okay again. Even if it's that, and I think, it's probably that, I will still test their reflexes, I'll still test their strength, I'll still test their sensation, because I want to know whether actually is it something else. And this is why we ask the questions that we do about cauda equina, which we did a couple of weeks ago. Really, really important. So if you're sitting on the loo and your legs are going numb, you'll recover quickly after moving around for a bit. Okay? Moving around won't help that. Yeah, it won't change it. There's no let up. They need to go to hospital straight away. That is an emergency and they need an operation. If they don't have an operation quick, the nerves around that region will lose their blood supply, and then the sensation and the control of the area that they have been affected, they will lose it forever. And this is why it's so bad. And that is what happens with cauda equina. The speed of the conduction block is important. And so we've seen this a few times and we've gone, okay, it's very likely that in your 80s, in your 70s, then you're going to have some disc degeneration, you can have some signal loss, height loss, disc bulges. It's more likely as you get older. But this is where the body is really clever, because the slower the compression, so if it's over weeks and months, the body can adapt to it. Yeah, if it's a really quick progression, doesn't like that at all. If this is a step-by-step gradual process, which is kind of what we see when we look at these MRI results, then that's we can deal with that, we can cope with it. But sometimes if the speed is really quick and it's happened really quickly, then we need intervention really quickly as well. The other thing that can happen is a chemical irritation as well. This is the other side of when a nerve gets irritated, and the two can be combined as well. A chemical irritation from the disc. Remember the nucleus before? We've got pro-inflammatory chemicals which irritate the nerve. Okay? And then we got an immune system response as well. If there's a leakage of nucleus, that nucleus was never meant to meet anything outside of that disc. So if it does, the body thinks it's an enemy and creates an inflammatory response. We get a chemical irritation to a herniation as well. The surrounding structures can also be linked in to the symptoms. If we think about radicular pain, if you've got a facet joint that is irritated and it's been there's some kind of inflammation in the joint space, that can irritate the nerve. It may not be coming from the disc, it may be coming from the structures around it. If you've got a facet irritation, that joint irritation will cause irritation to the nerve, which may then give you radicular symptoms. It's not necessarily because of a compression, it can be because of a chemical irritation. There's other reasons as well as mechanical irritation. It can also be because of a tumour. Malignant tumours, cancerous tumours, release inflammatory chemicals. If there is a tumour in or around the spine and the nerve root, then that can irritate the nerve. It's not the tumour compressing the nerve, it's the chemicals that are released by the body and by the tumour. Neighbouring structures can chemically irritate the nerve, basically, things that are around it. It's not just all about mechanical compression. But obviously, you can have a bit of both. You can have a bit of mechanical compression, which then causes a chemical irritation. This is why it's really difficult to say it's that is causing the problem. Chemical irritation from mechanical pressure. Haven't we just talked about this? Well, yes, we have. So mechanical pressure was crowding out, so this bit, bowstringing, so compression here, and then absolute compression from the boulder. These can irritate the nerve and cause an inflammatory response. Mechanical pressure can cause chemical irritation. Like I said, it's not that simple. Does a disc herniation cause pain? Maybe. It depends. Sometimes it does, sometimes it doesn't, and that is the really annoying thing about these things. This is a paper, when is it, from 1994, so it's a pretty old one, but extrusions were linked to 26% of people with radicular pain and only 1% of asymptomatic. So there is a possibility that if you have an extruding bulge, we saw that earlier today, that is linked to 26% of people with radicular pain, but those that were asymptomatic, only 1% of them had an extrusion. Potentially a disc herniation could create radicular symptoms. Some have radicular pain but no herniation. The possible reasons for that, remember, radicular pain was nerve root irritation causing symptoms down the leg following the line of the nerve, but no herniation. So the possible reasons that are surmised from this paper is the MRI is not sensitive enough to pick it up. There may be some irritations at annular fissures within the disc that you just can't see. Dynamic herniation, when you lie down, they reabsorb. When you stand up, they come back. That could be a reason. The problem may not be the spine. It could be some kind of other syndrome that radiates down the leg, or it's gone now because by the time they had the MRI done, things have changed. Good question here. Is there a difference between herniations above or below the conus? It's unlikely that you'll herniate at the level of the conus. It's more likely that it's going to be lower down, so L4, L5, L5, S1. But if you did, and it was a central bulge, then that if you imagine where that all of the nerves come out from that area there, so that would cause widespread disruption to all of the lower extremity. Whereas with the cauda equina, because it's like a horse's tail, it may only impact a couple of the nerves because the other ones will move out of the way. And that was one of the things that was mentioned with our way of kind of dealing with it. If it's a slow progress, if it's slowly starting to come out, then the cauda equina nerves, the kind of nerve roots that are longer, they just move out of the way. Yeah, so that's one of the things that we think might be happening. But that's a good question. Disc herniations, why they happen, why we might get certain symptoms. Some of it might be mechanical irritation, some of it might be chemical irritation, some of it might be a combination of the two. So it's really hard to tell. I think the key thing is those questions that we looked at a couple of weeks ago on cauda equina. Are the symptoms bilateral? Have you had any bowel or bladder changes? Unusual sensations that they've never really felt before, they're having trouble sleeping. All of those kind of things are red flags, plus loss of sensation, loss of reflex, loss of power. Again, if you don't know how to test those things and you're not really sure what to do, then send them off to someone to assess it like straight away. Even if you just go, do you know what, you need to go to A&E just to get checked out. I had a lady who had emergency surgery. She came into clinic. She'd had some ridiculous symptoms before, and they'd cleared up with just general exercise, so all was good. And then this one day she came in, hadn't seen her for a while, and her symptoms were completely different. She had drop foot, so she wasn't able to dorsiflex her ankle. She wasn't able to lift her big toe against my pressure. She'd lost her reflexes and she'd lost sensation all down the outside of her leg. So I said, you need to get to hospital now. They literally operated on her that day. That's what can happen. So hopefully you understand why now those things happen. And although we can't, my kind of what I did with that woman, I had no idea what was causing it, but I knew something wasn't right. So now hopefully you'll understand why things aren't right. They can be for several reasons and we'll never know.